Participation in tonight's program, you are able to receive 1 AMA PRA Category 1 CME credit. To do so, you must complete the post-test and evaluation that will be distributed at the end of your program. Your certificate will be emailed to you within 4 weeks of receipt of your completed evaluation form. The downloadable resource guide was provided to you in the reminder email sent out earlier today, and we will also post it in the chat below. We encourage you all to engage in tonight's program and contribute your knowledge to the activity. At this time, I'm pleased to hand over the program to our faculty presenters, Dr. Blaiss and Dr. Chupp.
Thank you, Cameron, and good evening, everyone. Thanks for joining us for this CME activity. I'm Dr. Michael Blaiss, a clinical professor at the Medical College of Georgia at Augusta University in Augusta, Georgia, and I'm joined this evening by Dr. Jeffrey Chupp. Jeff, you want to introduce yourself?
Sure, Michael. Great to be here. Looking forward to the discussion. I'm a professor of medicine in the Division of Pulmonary and Critical Care and Sleep Medicine and the director of the Yale Center for Asthma and Airway Disease, pursuing research in severe asthma and running clinical trials in New Haven, Connecticut.
Great. So here are our faculty disclosures for this activity. And we have 3 learning objectives for you this evening. One is to describe the unmet needs with the current severe asthma therapies and the contributions of the airway epithelium and hyperresponsiveness in the disease. We also want to explain the involvement of alarmins in severe asthma and the rationale for targeting these upstream cytokines in controlling the disease. And lastly, and very importantly, apply newly approved treatments that address the alarmin pathway in severe asthma in the appropriate patient types. So, Jeff, why are these objectives so important this evening?
Well, Michael, I think we're in a paradigm shift in the management of asthma with changes in the guidelines and the addition of maintenance of rescue smart therapy, single maintenance and reliever therapy for patients with asthma. And we've had the development of biologics that have against T2 inflammation that have really dramatically changed outcomes for patients. And so I think we're in a paradigm shift about recognizing that the center of the disease is at the epithelial layer, and that it involves both inflammation of the epithelium as well as bronchospasm, and that we need to really address both airway hyperresponsiveness and inflammation when we treat the disease. So I think that will be increasingly clear as we go through our discussion tonight.
Yeah, I totally agree. I mean, we are going through a major paradigm shift in the management of asthma, and I think it's very exciting, because as we'll talk about, so many patients that we still take care of, especially as specialists, they still continue to have such severe problems and high use of oral corticosteroids. So what are we to expect this evening? We'll do an overview of severe asthma therapies and how the airway epithelium and upstream mediators come into play. And then we've got 2 interactive case reviews with opportunities, in fact, for everyone on this call to participate. You can respond to the program polling questions that will open in your Zoom window. And we'll discuss the decision options in these cases. And to contribute to the discussion, you can use your Zoom chat function and send us messages, or come on and speak to the reaction button located at the bottom of the Zoom window and click to raise your hand. And as already mentioned, a take-home resource guide will be sent after the program to your email. So really exciting program this evening. So with that, let's start with current therapeutic approaches to severe asthma and unmet needs of therapy. So I'm sure everyone is familiar with the GINA guidelines, the Global Initiative in Asthma. These are the latest ones, 2022, that were published just a few months ago. And here we're looking at the most severe patients that we take care of, looking at how to assess and treat severe asthma phenotypes. So this is a decision tree for those difficult to treat severe asthma patients. And again, we're talking about the adult and adolescent population. So if we look here, it talks about assessing the asthma phenotype and the factors contributing to symptoms and quality of life and exacerbations, and then talks about when to consider an add-on type 2 targeted therapy in those patients, again, that have poor control with high-dose inhaled corticosteroid long-acting beta agonists. Very importantly, as we know, you have to consider the local payer eligibility criteria and the patient's comorbidities and predictors of response. And along with that, obviously, cost. We know the dosing is different on these agents, the route of administration, and patient preference. So you'll notice here it says which biologic is appropriate to start with. So you see the eligibility here for anti-IgE and anti-IL-5 and the IL-5Rs and the anti-IL-4Rs and the anti-TSLP. And basically, it's what we see in the package insert as far as what patients, in fact, qualify for use of those particular treatments. I think very importantly, though, over on the right, you see the predictors of asthma response. And these can be very helpful in determining, again, which one we may go to in the patient population. So if you look at anti-IgE, it talks about a blood eosinophil greater than 260 and ANO greater than 20. Less predictive allergen-driven symptoms, childhood onset asthma. For the IL-5R, again, the biggest thing is higher blood eosinophils, more exacerbations of the previous year, adult onset asthma, nasal polyposis. And for the anti-IL-4Rs, again, higher blood eosinophils and higher ENO, and we see the same thing for anti-TSLP. So these can help us as far as determining where we may want to go first in choosing a biologic for a particular patient. Now, what do we know about the real world use? Because obviously biologics have been around a long time. Omalizumab now, I think it's close to 17 years. So this is a study that looked at the real world use of biologics, including patients that were on the International Severe Asthma Registry and the US Chronicle Study. And you'll notice here that almost 80% continued their first biologic. But I will come back and mention, I think this is important, just because they continued that biologic and didn't switch didn't mean they were under absolute control, and that was shown in the study. 10.2% stopped the biologic entirely and never started another one. Almost 11% switched. And then you can see over toward the right, the most common first switch, which was omalizumab to one of the anti-IL-5s. And then the next most common was between the anti-IL-5s. And again, these are the ones that have been on the market, in fact, the longest. So why was there switching? Not surprising. The main reason was insufficient efficacy. Some patients was adverse events. Now, in the US Chronicle study, they said greater than 90% continued their first biologic. But again, when one looks at that data from the study, a lot of patients, though they didn't switch, still had significant flare-ups associated with their condition. Now, there's no doubt, and I think all of us would agree with this, that in fact, we could do better. In fact, we know that there are a lot of patients out there that are GINA 4 and 5 that continue to have frequent use of oral corticosteroids. So this study by Tran, which you see the results here, 23% 4 and 5 GINA were classified as high oral corticosteroid users. Now, what they did is this looked over these patients over approximately a 2-year period of time, and they were classified as high oral corticosteroid use if over a 3-month period they required more than 450 milligrams of prednisone. So you can see almost a quarter of those patients did during that period. And then one of the things that I think we all know, type 2 high asthma is not the only type of asthma that we have out there. And in fact, there are several clinical studies show that about 50%, in fact, are type 2 low. And if you do transcriptome analysis, that number, in fact, is even higher. So definitely we can do better than what we had been doing as far as the care, especially of these classes of patients. So Jeff, I have another question. What are the current unmet needs in severe asthma?
I think you've highlighted it very well, Michael, in your discussion, or in making it easy for me to answer the question, which is that first of all, a lot of patients are doing very well with biologics, but there's still a lot of people on high doses of ICS/LABA who are uncontrolled, and we know that a high percentage of patients who are eligible for biologics are still not receiving them. The other unmet need is T2 low disease. Until recently, which I think we'll get into more, we have not had a biologic that addresses non-eosinophilic, non-allergic asthma. So this is something that's really, I think, going to be a focus in the future, understanding those pathways and mechanisms that drive T2 independent disease, and will allow us to achieve better outcomes in the patients that are out there, as well as educating people about what is available now in patients with T2 high disease, so that the patients that are eligible for biologics will receive them.
Great. No, all of that is, I totally agree. So even though we've come a long way, as we mentioned, we still have a ways to go. And again, hopefully with these newer treatments, we'll have another large group that we can get under better control with their disease and decrease the need for steroid therapy. So I'm going to move on now and talk about airway hyperresponsiveness and epithelial inflammation, a renewed appreciation for their role in severe asthma. And very important, the amount of information that continues to come out in the literature related to the airway epithelium as the first line of defense. So obviously, the structural effect here of the epithelium, with the epithelial cells, with their tight junction proteins, and the mucus layer. But also very importantly here is the immunologic role. And beyond just Ig-mediated sensitization, we have epithelial receptors that trigger the T2 immune response, not only by allergens, but also viruses. So what we're talking about here is in fact the epithelial alarmins, TSLP, IL-33, and IL-25. And they're very important, being activated in the epithelium, because they can drive both the innate immune system through primarily the type 2 innate lymphocyte, but also eosinophils, basophils, mast cells, and produce type 2 cytokines that have their feedback on the epithelium. And then also related to adaptive immunity, where these cytokines, these alarmins, can activate the dendritic cell activation of the Th2 cell. And again, we get the production of IL-4, IL-13. And these are extremely important, leading to changes in the epithelium, where we go through an epithelial mesenchymal transition. We have increased goblet cells, increased mucus production. We see changes that occur with increased collagen deposition and therefore fibrosis occurring in the airways. So we really have learned a great deal about the importance of the airway epithelium related in our patients with asthma. Also very importantly is a concept we've all been familiar with since medical school, and that is airway hyperresponsiveness. And that is a hallmark and really a poorly understood component of asthma, but it definitely correlates, as we know, with the severity of disease. So what leads to airway hyperreactivity? We have structural changes, but we also have variable changes related to acute effects of inflammation. And if you look over at the right, if one does a methylcholine, excuse me, or histamine challenge, You can see here the severe asthmatics, it takes a much lower level to cause a 20% drop in the FEV1. So there definitely, again, is that relationship between airway hyperresponsiveness and the severity of the patient's asthma. And you can see this quote by Buzzy, dissecting whether structural or inflammatory changes influence airway hyperreactivity will provide greater insight into this mechanism. Emerging data suggests that the structural changes of the airway contribute to airway hyperreactivity, and that these structural changes include remodeling and smooth muscle hypertrophy. So, Jeff, couple of questions here. Do epithelial abnormalities contribute to airway hyperreactivity? And does any of this point to any potential clinical target? Something we haven't really thought about, I think, with other biologics in the past for our asthma patient.
Well, I think the answer is obviously yes, there are abnormalities, and it's primarily due to the stress response in the epithelium. And as we're appreciating the release of cytokines by the epithelial cells when they're stressed, that contributes to airway hyperresponsiveness. This is through a number of cytokines that are T2 cytokines. For example, IL-13, we know, it's a very important contributor to airway hyperresponsiveness, but also now increasingly recognizes the role of alarmins that you've touched on that also contribute to increasing airway hyperresponsiveness. So this has made these cytokines particularly relevant as targets, both as anti-inflammatory mediators, but also in their relatively direct effects on smooth muscle function and constrict airway hyperresponsiveness and smooth muscle contraction.
Great. Well, I'm going to turn it over to you to continue our program.
All right, great, Michael. Thank you very much. So let's drill into this concept a little bit more and just really highlight the importance of these new cytokines in the development of inflammation and airway hyperresponsiveness. On this slide, you can see the bronchial epithelium at the top of the slide with the various cell types that are relevant to asthma, including the epithelial cell that's ciliated in brown. You can see the goblet cells in green that have mucus in them, as well as the basal cells in blue. And what's important to recognize is that these cells are forming a barrier between the airway and the immune system and the airway wall. And so they are not just a barrier, but they're also a sensor. So when there's an injury or a substance that comes into the airways, such as virus, bacteria, allergens, cigarette smoke, this can stress the airway cells, and they respond to that by producing alarmins. These are IL-25, TSLP, and IL-33. These are the most appreciated alarmins at this point in time. These cytokines then induce responses. And on the left, you can see the classic adaptive response that they can contribute to, which is the dendritic cell, which takes an allergen and processes it and presents it to a naive T cell and induces that to become a Th2, a memory T cell that produces IL-4, 5, and 13 that contributes to the production of IgE against the allergen, and IL-5 that recruits eosinophils from the bone marrow. They also can contribute to the development of eosinophilic inflammation independent of IgE production. This is through another cell type you can see on the right-hand side of the screen in tan in the upper right, called an innate lymphoid cell, an ILC2 cell. These cells make a lot of IL-13 and IL-5, but they don't make IL-4, so they contribute to the recruitment of eosinophils to the airway, but not in IgE production. And this is relevant in the clinic because we recognize now, as opposed to 20 to 30 years ago, that there are patients who have asthma with eosinophilic inflammation that don't have allergies. So about that can be as high as 15% in 50% in some series. So many of the patients have allergies and eosinophilic inflammation, but a lot of them have eosinophilic inflammation independent of allergies. And this is why we now do CBCs on patients in the clinic, so we can identify these eosinophilic non-allergic patients. So next slide. So many of these alarmins are important, and they have somewhat different but overlapping functions. So TSLP is the best known. It drives multiple pathogenetic effects on the airway, including AHR, mucus hypersecretion, and inflammation, contributes to remodeling. This has been shown in both translational studies as well as in vitro models. Activates dendritic cells to produce T2 cytokines, as I showed you, and can also activate mast cells, all independent of IgE. So not always dependent on IgE cross-linking on the surface of mast cells, and can also activate neutrophilic responses and contributes to T2 low inflammation and neutrophilic inflammation, and is likely important in these patients that we call low T2 or neutrophilic asthmatics. Next slide. IL-33 is similar to TSLP, has overlapping effects, and can contribute to AHR and T2 inflammation as well. And as you'll see, there are drugs against IL-33 pathways, molecules in development now. And then, of course, IL-25 is the least studied of these cytokines. It is also important primarily in T2 inflammation, and acts with other T2 cytokines to induce responses. Next slide. But at this point in time, we only have one drug in the clinic against the alarmins, and this has really been approved within the last year and is a first-in-class drug that blocks that binds to TSLP and inhibits its effects, and is indicated for add-on maintenance for patients with severe uncontrolled asthma, 12 years and older, independent of any baseline biomarker. Next slide. So this is some data from the Pathway trial. This is the phase 2b study that helped get the approval for Tezepelumab. And what you can see here is the reduction in annual exacerbation rates compared to placebo in these patients. You can see these are patients treated both 2 weeks and 4 weeks with different doses of Tezepelumab. The approved dose is 210 milligrams every 4 weeks. But what you can see here is the placebo patients during this nearly year-long trial, dosed every month, and the placebo patients had an exacerbation rate of 0.72 during the trial, and patients treated with Tezepelumab had a significant reduction in exacerbation rate down to less than 0.3 or 0.27 for patients receiving 70 milligrams. In blue, you can see 0.2 in those receiving the approved dose, which is the 210 milligrams every 4 weeks. And then in red, you can see patients 0.23, patients dosed with 280 milligrams every 2 weeks. So you can see the basis for choosing the every 4-week dosing at 210 milligrams. Next slide. But what's also very exciting here is when you start to look at the subgroup analyses. That was in all comers, the primary endpoint that I showed you. But when you start looking at patients by different biomarkers, so were these patients high eosinophils or low eosinophils? Did they have high nitric oxide levels or low nitric oxide levels? Did they have high Th2 status or low Th2 status? what was the difference in response? Because up to now in the asthma world, we've really been dealing with agents that have primarily worked in patients with high T2 signals. So when you look at the data from the Pathway trial, it was very exciting to see here that when you looked at patients with low or high biomarker status, regardless of the biomarker you looked at, there was a strong response compared to placebo. You could see blood EO counts of 250 here on the left of the slide, less than 250 or greater than 250, had similar responses compared to placebo, using a cutoff of 24 parts per billion for exhaled nitric oxide levels, a similar response between the high and low groups. And then Th2 status, that was by allergen, perennial allergen status. You could see similar response with low versus high T2 status, regardless of the dose given. So again, very nice response showing that this drug works in both low T2 status patients as well as high T2 status patients. And this is the reason why the drug was approved independent of a baseline biomarker status or a phenotypic label to the asthma. It didn't require allergic or eosinophilic asthma as a phenotypic marker for approval. Next slide. Now here's data from the Navigator study. This is the phase 3 trial that was published last year in the New England Journal of Medicine by Andrew Menzies-Gow. I'm one of the authors. You can see here the primary endpoint at the top of the slide on this forest plot. Overall in that phase 3 trial at the 210 milligrams every month, there was a significant improvement compared to placebo. Hence the blue square to the left of the line of identity number 1 in overall outcome. But again, in this trial, which was separate from the Pathway study, but confirmed the results of that phase 2b trial, looking at all these different ways of categorizing patients as high or low T2 disease, the response was still significant compared to placebo. It performed better than placebo. You could see EO count cutoff of 300 here in the second grouping, EO cutoffs of 150 or 300 or above 150, nitric oxide levels that were high or low at baseline or grouped, as well as allergen status. Now, that isn't to say that this drug looks like it performs better in patients with higher T2 status compared to lower T2 status. But what's very exciting is to see that even in the low T2 patients, it performed better than placebo. And that is unique in the biologics field. Next slide. Now, lung function outcome. This is in the Navigator study. In the overall patient population, you could see here significant improvement in lung function, as you would expect based on what we've discussed about the biologic properties of TSLP on airway hyperresponsiveness and epithelial cell function. Next slide. And just before you go back for a second, Michael, if you don't mind, this was a response shown within 2 weeks. This is seen with other biologics. But you could see here up close to 200 cc's within 2 weeks that was maintained throughout the year-long study. Next slide. Now, it isn't all about exacerbation rates and lung function. And one of the things that's also been looked at in all of the pivotal trials is asthma quality of life and disease control. And you could see that on this slide. ACQ-6, AQLQ, ASD, asthma symptom diary, asthma quality of life questionnaire, and asthma quality of life score. You can see that there was a significant improvement compared to placebo in all of these outcomes. That, again, was difficult to achieve in biologics because of the strong placebo effect that is seen in quality of life scores in patients in clinical trials because of the clinical trial effect. But in this trial, you could see that these were statistically significant for all three of the instruments used. Next slide. Now, it hasn't all been perfect for Tezepelumab. This is data from another trial, the SOURCE trial, where it was looked at whether Tezepelumab could reduce systemic steroid use. You could see here that the overall trial at the top of the forest plot crosses the line of identity of 1, so there was not a significant improvement compared to placebo, even though more patients were able to get off to improve their OCS dose compared to placebo. But there was some evidence of improvement in those patients with higher T2 disease, as expected. Next slide. So here's where we are with effects of these biomarkers of inflammation. If we start at the top here, you can see that Tezepelumab has shown in these trials to reduce all the biomarkers of interest in asthma at this point in time. Dupilumab decreases nitric oxide levels and IgE levels, but has a known effect on increasing eosinophils early in treatment courses, but over time can decrease them. Omalizumab decreases FeNO and IgE levels. As we know, although bloody IgE levels can increase on drug because of the drug binding to IgE. Mepolizumab reduces blood and sputum eosinophils, as well as the other IL-5 drugs shown on this slide. Next slide. Now, there's also some recent data within the last few months looking at airway hyperresponsiveness in a small study of about 40 patients, looking at mannitol responses, which a test of airway hyperresponsiveness. And you can see in this relatively small study, there was not a significant improvement in the week 12 airway hyperresponsiveness signal compared to placebo, although there was a decrease. P-value was 0.06, very close, but that was the primary endpoint. It did not reach statistical significance, but should be noted that this was only a 40-patient trial. Next slide. So we have other anti-alarmin therapies coming down the pike. Itepekimab was recently published in conjunction with dupilumab. This was an anti-IL-33 biologic that showed improvement in asthma control, in loss of asthma control. It was a steroid withdrawal trial. Did not show a benefit when was used in conjunction with dupilumab, so it worked alone, but not better in combination. There's Itepekimab, another phase 2 trial, another anti-IL-33 drug looked at in patients with eosinophilic disease. And Astegolimab, which is an anti-IL-33 receptor, the ST2 receptor drug. So these are all in phase 2 and reduced exacerbation rates. And so I think we will see how these drugs do in phase 3 trials, but it looks like anti-alarmin therapies are here to stay. Next slide. So, Michael, where do you position anti-TSLP therapies in the current landscape of asthma management?
So obviously, as you mentioned, they had very broad use, and the label, again, from the FDA verifies that. So definitely for patients that are type 2 low that do not qualify for any of the type 2 high, do not qualify for type 2 high biologics. So I think it's great as I mentioned previously, that's at least 50% of the patients that in fact have asthma. So that's a large group that can benefit from anti-TSLP. And then there's no doubt from the data you saw that this is an excellent agent in patients with type 2 high disease. So I think it gives us another option in those particular patients. And again, we're not bound by any particular blood studies as far as whether we can use this particular product or not. So I think it's going to, as we're already seeing, there's a high number of severe uncontrolled asthma patients that this product will make a major difference in the control of their asthma.
Fantastic. Yeah, totally agree. Next slide, please. So this is where we are really, and how we approach patients. I think this is a nice slide that visualizes how we manage patients in the biologic era. What you can see on the left-hand side, when a patient enters into this algorithm, we usually assess them in 3 to 4 months and determine if they've had a good response. At that point in time, we determine whether to continue them or switch them. Usually, I think most physicians will end up with a 6-month trial because it can be hard to tell within 3 to 4 months if the patient's improved or not, and it takes a lot of work to get patients on drug. If they've responded, they continue on that drug. As you can see, 90% of patients stay on drug, as Michael presented earlier in the presentation. But if they switch, they will switch to a different biologic, either in the same class or potentially in a different class. Next slide. So asthma is a combination of many pathophysiologic features. That really the centerpiece here is inflammation at the epithelial layer of the airway that contributes to airway wall inflammation, mucus hypersecretion, and airway hyperresponsiveness. Despite the many therapies we've developed over the years, we still have a lot of patients that are poorly controlled. We have novel biologics that have improved outcomes, but we need to get the patients that need these drugs on them. Phenotyping patients is important to understand their triggers and characterize their underlying disease so we can properly select an agent for them. And a broad range of interventions are now available, including anti-alarmin therapies and anti-TSLP therapy that's going to help us manage these patients into the future and hopefully achieve remissions in this disease. Next slide.
Thank you, Jeff. That was a great overview giving us the information as far as the clinical studies and the efficacy and safety of anti-TSLP therapy. So with that, we're going to move on now to our first case study. So here we have Lou, a 42-year-old male, and he presents to your office for routine follow-up 8 months after initiating anti-IL-5 therapy for severe asthma. So his medical history was diagnosed with asthma at 28, has a history of chronic allergic rhinitis with a positive skin test to house dust mite and mold. And his asthma had worsened over the past 8 years, is uncontrolled despite high-dose inhaled corticosteroid, long-acting beta agonist, and tiotropium. And he was assessed for biologic response at 4 months. And as we'll see, the response was unclear. So what's his current medications? He's on anti-IL-5 therapy administered at home, sub-Q every 4 weeks, medium dose inhaled corticosteroid, because that was stepped down from high after 4 months of add-on therapy, a leukotriene receptor antagonist, and a short-acting beta agonist is needed. So here's his physical exam and test results. Had a normal BMI. On HENT exam, his terminates were pale swollen, but no polyps were seen, and his chest was clear. So his baseline lab showed an elevated IgE of 264 and specific Ig to house dust elevated 37 international units. His ENO was elevated 68 parts per billion, as was his blood eosinophils at 360. And his FEV1 was 66% of predicted pre-bronchodilator. Once he was given a bronchodilator, he showed a 13% reversibility. So here we're seeing his baseline and now his current symptoms after being on the anti-IL-5 therapy. So we can see his symptoms here. Baseline were 3 times a week with multiple times per day, 1 time a week. Now they had dropped to twice a week with multiple times per day, once a week. No change in interference with activity with some limitation. If we look at steroid exacerbations, they did drop. Baseline, it was 4, previous year 2 severe, and currently in the last 8 months, he's had 2. Nighttime awakenings improved from 3 to 1, and his ACT improved from 15, 17, but still not under control, as we know 19 and above for the asthma control test is control of the disease. And he tells us that he feels better, but he still worries about his asthma. And it interferes with his goal to stay fit. So he's partially satisfied with his current treatment plan. So this leads to our first question. Based on the information presented, is this an adequate response? Yes, no. It's tough to tell. I need more information. It's up to Lou if this is the response he's after. So let's see your answers now for the polling question. So as we see here, the number one answer was no at about 67%. 27%, it's tough to tell and I need more information. And then the other 7%, it's up to Lou if this is a response he's after. Now, if you think about it, again, D is an important answer because this gets into shared decision-making. And getting the patient's thoughts about how he's doing his treatment is extremely important. And again, more information may be beneficial, but you have to agree with the no group in the sense that, unfortunately, we could tell from his baseline to his current symptoms, well, they're a little better, but I think all of us would want our patients under better control than what we're hearing about from Lou. So let's keep going. So let's look at his current lab test versus his baseline. So what changed after he was on anti-IL-5 therapy? So his total IgE really didn't change, 264, 253. Same we can say for exhaled nitric oxide. He did definitely show a drop in blood eosinophils from 360 to 66, and really no change, as you can see here, in his lung function and reversibility between being on before the anti-IL-5 and then currently. So this leads to the important aspect of shared decision making, because in most of these cases, as we know, there is no right or right answer, and we do need to get the patient's preferences and values as far as determining what may be the best match, in this case, the best match as far as a biologic for Lou. So all options are discussed with Lou, and the findings from his exam and lab results were reviewed with him. So he stepped back up to high-dose inhaled corticosteroid, and after, again, a great deal of discussion with Lou, he elects to initiate a trial with another biologic with the hope of a greater response. So what change would you make to Lou's add-on biologic? Would you switch to a different anti-IL-5 5R, or an anti-IgE, or an anti-IL-4R, or an anti-TSLP? So we'll open up the poll and let you give us your answers. Okay, so no one said add a different IL-5/5R, though one could still say just because they didn't respond to one, may respond to a different one. So we can't really say for sure here if they wouldn't. We got 13% said anti-IgE, and he definitely qualifies from his IgE level and a positive perennial skin test. Anti-IL-4 biologic was 20%, and again, his values would qualify him for that. And then the highest number, 67%, was anti-TSLP, and again, obviously, he would qualify for that preparation. So there are lots of different biologics here that, in fact, one could do with shared decision making as far as determining with Lou which would be the best one to go to for switching from the anti-IL-5. So with that, it's important when one is doing shared decision making that they understand the differences between the different biologics. Obviously, cost is an issue, and that may play a role, and they need to understand the outcomes associated with each one. So we have anti-IgE here. I won't go through all the things that we know, but all that's important to go over with Lou. The same goes for anti-IL-4. And then we've already heard on our discussion the role of anti-TSLP. And all of these, in fact, are reasonable choices for a switch for Lou. So with that, I'm going to turn it over to Jeff to lead us through the second case this evening.
All right, so we'll do this one relatively quickly so we don't go over with time and we have a few minutes for questions. Next slide. So this is Beth. She's 38 years old with late onset asthma, so adult onset disease, which is always interesting. She presents to the office for follow-up evaluation, recurrent viral infections that are causing flares of disease. She was diagnosed 3 years ago at age 35 after an exacerbation requiring hospital admission. This was after being exposed to smoke from a wildfire. She has a previous smoking history, 17 pack years, quit after asthma diagnosis. She's hypertensive, and her BMI is 31. She's on high-dose ICS-LABA, SABA as needed, and lisinopril. Next slide. So she has symptoms 3 to 4 times a week, multiple times per day, 2 times a week. She has activity limitations, 3 flares in the last year requiring OCS, multiple nighttime awakenings, and her ACT score is 14. So she's really severe by multiple characterizations, including her ACT score and OCS requirements. And she's adherent to medications. She also reports a partial response to OCS. So she has these protracted flares that we sometimes see in these patients. Next slide. IgE is low. All her biomarkers are low. Nitric oxide 16, EOs 78, and her FEV1 65 with reversibility. So she has classically low T2 disease by all biomarkers. Next slide. So what would be your next step with Beth? Add on a LAMA, macrolide, azithromycin 3 times a week, both low dose OCS or a biologic. Next slide. So here's the poll. So we see the answers coming in here. I think there's a good mix of add-on Alama to add on azithromycin and Alama, or add a biologic. So nobody would go with azithromycin alone. I think that's really quite interesting, and I like this choice that people are trying to go with, because they're going with guideline basing increasing of LAMA, and then going with macrolide therapy as well to see if they can achieve control and then maybe dial that down, or a biologic. Next slide. So Beth has started on TO and azithromycin, so right on the money. Students, very good. In addition to continuing her high-dose ICS-LABA, her symptoms improved, but she has another flare requiring a steroid taper after stopping the azithro. Next slide. So what would you do now? Just go on long-term azithro? Try OCS now, try the biologic, consider bronchial thermoplasty. So again, we have a good mix of responses coming in. A few people would add systemic steroids. A few would add azithro. So we have 10% for both of those. Bronchial thermoplasty, 8%. If you could get it approved by insurance, that would be great. It would be something to consider. That's been our challenge with that. And then biologic, addition of a biologic's 81%. So I think in this day and age, most of us are going to move to a biologic because we know they work very well, and we have options for this patient, and we can get them approved. Next slide. So chronic azithromycin has been looked at in non-T2 disease and has shown some benefits. There is concern about long-term toxicity. Hearing can be affected, as well as antibiotic resistance. Low-dose OCS, of course, is something we want to avoid because of the long-term morbidity associated with systemic steroids. And I talked about bronchial thermoplasty and the fact that it could work in this patient, but approvals have been challenging in this day and age. And that now we have a biologic for this kind of patient, anti-TSLP, Tezepelumab, which would be a great option for this individual. And because it has been shown to work independent of biomarker status. Next slide. So I think we have a few minutes here for questions. Michael, should I hand it back to you?
Yeah. So if, again, any questions, if you'll put them in the chat, we'll be happy to try to answer them for you this evening.
So I do see one question here. Should I take it?
Sure.
It says, pretty clear non-T2. Could you start biologic without biomarker tests? So this is a question from, I think the answer is yes. I think in this patient's case that in Beth, it would be definitely an option. I don't believe you would need a biomarker to apply for approval for Tezepelumab based on the indication that's been approved by the FDA. Although I will caution you, insurance companies can throw you curveballs, and it's different in every state. But I certainly think you could do that. Would I do that? As an asthma specialist, I will phenotype my patients. I want to understand their allergic status and their T2 status so that I can track their disease appropriately. It helps me understand if there's non-pharmacologic interventions I can consider, whether there's other workups I should consider for aggravating factors such as GERD, environmental issues that can be mitigated. So I will continue to phenotype my patients, even though we have Tezepelumab available.
So I see another question. How long do you wait before stopping LABA after starting a biologic? Well, so I kind of give my opinion, Jeff can give his, because there's not, true guidelines or FDA approval on in fact how you do start weaning medication. But if the patient has been stable for a minimum of 6 months on a particular biologic, so they're usually also on that time, usually anywhere from medium to high dose inhaled corticosteroid long-acting beta agonist. And many of my patients also on a LAMA. What I'm going to typically do first is decrease the total. So in other words, put them on, if they were on high, put them on medium dose inhaled corticosteroid long-acting beta agonist. And I want to be slow in titrating down the patient. So I don't just like, well, let's remove all LABAs or let's remove all LAMAs, but really want to go a slow process because I don't want exacerbations to occur, and do it slowly over time to make sure, in fact, my patient stays safe, stable. But I would definitely, if I'm on high dose inhaled corticosteroid long-acting beta agonist, the first thing I want to do is drop that to medium.
Mm-hmm. Yeah, I'll add to that, Michael. I agree. I think in my approach is generally the same. I really individualize it to each patient, depending on their response. Sometimes the responses are dramatic. I usually go with tapering non-anti-inflammatory drugs first. So I will taper, LAMAs and leukotriene inhibitors and things like that have are less potent on inflammation, and then move towards the inhaled steroids dosing as if the patient responds. And I always give the patient a plan so that they know that if they decrease and they notice their symptoms return within a few weeks or worsen, that they go back up to that previous level of medications and they contact me, and to in an effort to help again reduce the risk of having that patient flare. There's another question: how well is Tezi covered by insurance? I think that's a question we're all learning about now. It's been available for about 6 months, and there are patient support programs available for all of the biologics. So I think that, given the complexity of the biologic space now, how it's increasing with the number of agents available, I think what we're going to start seeing is that insurance companies are going to have their preferred agents in this class. And so depending on the patient's insurance in the state, they may require the patient to be on a certain one biologic first, trial them in order before they are allowed to move on to another biologic. So where Tezepelumab fits in the current context is not yet known, but we've in Connecticut at our site, we've had good success getting approvals.
I don't see any further questions. I guess I'll turn it back over to Cameron.
Thank you so much, Dr. Blaiss, and thank you everyone for attending the program this evening. I really hope that you all enjoyed this interactive format and are able to walk away with things that you can implement into your own practices. We just want to thank you again, Dr. Blaiss and Dr. Chupp, for your time and your insight today, as well as AstraZeneca Pharmaceuticals for their support. The post-test and evaluation link is on the screen. You can use the QR code as well, but we will place it in the chat box below, and it will be distributed via email for anyone who did not complete the evaluation within the next week. We do also welcome feedback on tonight's activity format. You can let us know your thoughts when you complete the evaluation, but thank you again to everyone who attended, and thank you, doctors, for facilitating the program this evening.